And like I said earlier, I hope you would learn from a thing or two from this webinar. Cardiovascular disease is known as one of the deadliest diseases that affect us as humans. In 2023, 1 out of every 6 cardiovascular deaths occurred in young adults. This shows that cardiovascular disease is no longer a thing for senior citizens or older people. It's because of this that we decided to plan on the webinar presentation for today, something that we believe would meet most of you, as every family has issues that are related to heart disease. For our webinar today, we have speaker Dr. Fur, who is a doctoral trained clinical laboratory scientist, very passionate about what she does. She's going to put us through today to tell you about cardiovascular disease-related tests. Typically, when you go see the doctor, they would order HDL, LDL, and total cholesterol. There's more to it. And we believe that by presenting this webinar to you, you'll be empowered. You'll be able to know what to ask your doctor to order, when to ask it, and why you are asking it. We just want to make sure that you are empowered with the information you have. I would hand over the mic to Dr. Fur, who will take us through this webinar. Thank you.
All right, thank you very much for the introduction. Let me just get over here to share my slides. All right, are you able to see my slides?
Yes.
All right. Okay.
So, before you begin, I want to for the webinar, we are going to ask. I'm going to ask questions that typically we expect patients to ask clinicians. That would enable Dr. Fur provide answers to these questions as a way to guide you on communicating with your clinician, or if you're a clinician, as a way to guide you on communicating with the lab on what test to order. So, Dr. Fur, the topic of today's presentation is Advanced Lipid Profiling. Cardiovascular risk assessment is a cornerstone of preventative healthcare. One of the tools used to evaluate the risk of adverse cardiovascular events is lipid profiling. Can you give us an overview of traditional lipid profiling and more advanced lipid profiling?
Absolutely. So the traditional lipid profiling that's been used for many, many decades includes your low-density lipoprotein, or LDL, high-density lipoprotein, or HDL, and sometimes the LDL-HDL ratio, usually your total cholesterol levels, non-HDL cholesterol, and then commonly triglycerides. Now, advanced lipid profiling, on the other hand, looks at more specific fractions like apolipoprotein B, apolipoprotein A, the ApoB to ApoA ratio, and also lipoprotein A. There is others, but these are the ones that we're going to focus on for today's presentation.
Okay, thank you. And the next question would be, let's help us take a look at traditional lipid profiling first. Can you give us a little more detail on the individual lipid fractions?
Of course. So LDL is what most of us commonly know as the bad cholesterol. So that's the main traditional biomarker used for cardiovascular risk assessment. And that's because it's associated with lipid deposition and plaque formation and further downstream atherosclerosis. HDL, on the other hand, is kind of its opponent, if you so will. It's what we know as the good cholesterol, and it's associated with the reverse transport of lipids. And therefore, there's a lot of evidence of the cardioprotective effects of this molecule. Then we also have our total cholesterol, and that is just the sum of all, and it includes all of the fractions of cholesterol, so your LDL, your HDL, VLDL, and all the others. Non-HDL cholesterol is exactly what it sounds like. It's your total cholesterol, and you just subtract the HDL, and that leaves you with a non-HDL fraction. And this therefore includes the VLDL, other remnants, and so forth. Now, triglycerides is completely separate from this. It is not included in the cholesterols. This is the primary transport form of fat in the body, and it is an independent cardiovascular risk factor separate from cholesterol. Now, some of us may have heard of this, so I wanted to address it. Why do high triglyceride levels interfere with LDL results if they're not included in the cholesterol pool? This is because commonly in the clinical lab, LDL levels are actually calculated and not measured directly. So LDL would be calculated as total cholesterol minus HDL levels minus triglycerides divided by 5. There's many variations of this formula. I just picked a rather simple one just to show how triglyceride levels play a part in this. So you can see if somebody has exceptionally high triglyceride levels, how that would interfere with your LDL value. So therefore, this formula is commonly used for patients that have triglyceride levels below a certain threshold. 400 is just an example here. It's individual to the lab methodology and analyzer you use. There is a way around this. So if we encounter a patient that has very high triglyceride levels, the LDL usually automatically defaults to the direct measurement. So there is a way to measure it directly, but that's not what's commonly performed in the clinical lab.
Thank you. Thanks for that detailed explanation. So now that we've discussed the lipid fractions individually, but does it matter how high a patient's good cholesterol is compared to the bad cholesterol?
So it's actually been shown that the LDL HDL ratio or the total cholesterol to HDL ratio are the more valuable indicator for cardiovascular risk compared to each value alone. So you will likely see on your lab work a fraction, either the total cholesterol divided by HDL or the LDL divided by HDL. And that's just a simple calculation that allows you to estimate how much reverse transport of cholesterol is happening in the body compared to lipid deposition. So this table down here, again, is just an example. Depending on your source literature, you'll find different cutoff points, but there is established values that show you that you have a higher risk of cardiovascular events the more bad cholesterol or LDL you have compared to HDL.
Wonderful. Thank you so much. Let's look at lipid fractions that are part of advanced lipid profiling next. Can you tell us more about apolipoproteins B and what clinical value it adds to cardiovascular risk assessment?
Yeah, so this is where it gets really interesting. Apolipoprotein B is actually the structural protein of all the atherosclerotic particles. There's only one ApoB per atherosclerotic particle, which is very important, and that is present in all the bad cholesterol. So LDL, VLDL, intermediate density, and also lipoprotein A, which we'll discuss later on. What this means, just to visualize this little graphic over here. So both of these patients would have an LDL level on their lab work of 100 milligrams per deciliter. But if you were to measure apolipoprotein B, the patient on the left would have a level of 6. The patient on the right would have a level of 12. So just counting that structural protein allows us to count the particles that are capable of inflicting injury to the arterial wall. So if you want to envision it that way, every single lipid particle of the LDL fraction that floats around in your arteries has the potential to damage your arterial walls. So on the left, that patient basically has 6 little bullets flying around in their arteries, capable of causing harm. The patient on the right has 12 little bullets flying around and therefore has a higher cardiovascular risk. But in the more commonly used lab work, if you just assess the LDL level, you would not be able to differentiate between these two patients.
Thank you so much. We move to slide 7, right?
Oh, yes, sorry. It did not move on for me. So here's another good example why this matters. So when comparing LDL levels to apolipoprotein B levels, there is a strong correlation because we discussed that ApoB is the structural protein of LDL. However, levels of ApoB vary between patients with the same LDL levels. So for example, in this study, they looked at new onset atherosclerotic cardiovascular disease in patients that had about the same LDL levels. So first, what you notice is that the higher your LDL is, the higher the rate of cardiovascular event. And that's something that's been long established in preventative medicine and in the literature. That's not surprising. However, when you look at these patients and evaluate which patient has higher levels of ApoB compared to lower levels of ApoB within those groups, the patients with the higher ApoB consistently have a higher rate of new onset cardiovascular disease. Now, one thing I wanted to point out here is that the group with the lowest LDL levels seems to have a slightly higher cardiovascular risk than patients with a slightly higher level of LDL. This seems very counterintuitive, but it's a very common findings in studies looking at lipid profiling and cardiovascular risk. Reason being is that these patients, the group in the 70 range, they're usually patients that are on statins. They're on active lipid-lowering therapy. So that means they have a history of significantly higher LDL levels. They have now been artificially lowered by statin therapy or other lipid-lowering therapy. But what is not commonly discussed with the provider and the patient is that the damage that has been done by the previously elevated LDL levels, that is not going to be reversed by statin therapy. All you can do is prevent further harm going forward. But these patients, they have reached their lower LDL target by starting their lipid-lowering therapy, but they're still suffering from the damage that's already been inflicted in the past. And that's the reason for the higher rate of cardiovascular events in this group.
Thank you. So far we've learned that ApoB is the more precise way to measure bad cholesterol. What about good cholesterol? Is there a more precise way to measure this as well?
Yes, so we have our counterpart here as well, and that is apolipoprotein A. Again, it's a structural protein of HDL. It's the same concept, your little graphic right here on the right-hand side in the upper corner. Both of these patients would have an HDL level in their lab work of 50 milligrams per deciliter. But if you look at the patient on the left, this patient would have 6 ApoA, and the patient on the right would have a level of 12. So essentially, the patient on the right has more particles in number that are capable of reverse transporting lipids from your arteries back compared to the patient on the left. So the patient on the right here would have a lower cardiovascular risk. And same concept, you can build the ratio of ApoA or ApoB to ApoA. Since we're counting particles now, it is more accurate than the LDL-HDL ratio, and therefore the better predictor for cardiovascular risk and clinical outcome. And that is true even in the patients that have reached their 70 milligrams per deciliter LDL target. When you look at this table with the ranges you're trying to achieve, the target ranges, you see the ranges from earlier for the total cholesterol HDL and LDL HDL, and they're this arbitrary, threshold of 4 or 2.5 compared to the ApoB to ApoA ratio. And here you can see that you're basically just trying to stay under 1. So since we're counting particles, we want to make sure that we're counting more good cholesterol particles represented by the ApoA number compared to bad cholesterol particles represented by ApoB. So we want a greater number of reverse transport than lipid deposition.
Thank you. So I've also heard a lot of talks about lipoprotein A, or they call it lipoprotein little a, depending on who is reading it. In the recent years, can you please explain how lipoprotein A, or LP little a, as it's called, fits into the picture of cardiovascular risk assessment?
Lipoprotein A is my personal little favorite. Those levels remain pretty stable throughout our lifetime. They're mainly genetically regulated, and lifestyle changes, diet, unfortunately, or fortunately, depending on what your lifestyle is, they have little to no effect on the lipoprotein A level. There's also currently no FDA-approved drug targeting specifically lipoprotein A, even though there are some in trials. So hopefully we'll make this a treatment target soon. It's structurally similar to LDL, but it does have an additional component that enhances adherence to the endothelium wall. Lipo-A also carries oxidized phospholipids, which encourage inflammation and plaque instability. And lipo-A promotes thrombosis by competing with plasminogen, so therefore interfering with fibrinolysis. So compared to LDL, lipo-A has increased inflammatory properties, and it promotes coagulation, and it also makes for more unstable plaques, all of which greatly increase cardiovascular event risk.
Thank you. So what are the official guidelines for utilization of advanced lipid profiling? That is tests, asking for tests beyond HDL, LDL, and total cholesterol. What are the guidelines for using the advanced lipid profile test?
Yes, so we'll look at all of those fractions separately. Let's start with apolipoprotein B, and I looked at a couple of different societies here. So first, the Canadian Cardiovascular Society, and they recommend use ApoB instead of LDL in patients with triglycerides levels greater than 133. So if you think back to our slide earlier, this threshold is significantly lower than what we deemed this the LDL calculation acceptable for. And they specifically recommend just going ahead and measuring ApoB instead of LDL just because it is more precise and accurate. The European Society of Cardiology and the European Atherosclerosis Society, they both recommend ApoB for risk assessment, period, for all patients, and it can also be used as an alternative to LDL, and it is preferred in patients with high triglycerides, diabetes, or obesity. Now, if you look at that little underlined sentence here, I think we all know that this statement will apply to probably the vast majority of patients seen in the U.S. healthcare system. So they are definitely saying that ApoB should be utilized more. Now, the American Heart Association and American College of Cardiology, unfortunately, have the weakest guidelines out of all of them. And they're just saying ApoB is a risk-enhancing factor if it's greater than 130 milligrams per deciliter. And there's a relative indication for patients with triglycerides greater than 200 milligrams per deciliters, but no specific indication that everybody should utilize ApoB. Now, looking at lipoprotein A, the Canadian Society recommends one-time testing in all adults, and that phrase one-time testing is recommended because we discussed it's mainly genetically regulated and not very affected by lifestyle changes. So it remains pretty constant. So it's really a one-time risk assessment to know your risk factor. But after that, until we have an approved drug and can target it, it's not going to change. They're saying it supports enhanced risk factor management and aggressive statin therapy, and if lipo-A is greater than 50 milligrams per deciliter. So again, we do not have a treatment target, lipo-A itself is not a treatment target. The thinking here is that we should control the lipid fractions that can use harm to our arteries, meaning LDL. We should control this as aggressively as we can in these patients, just because that's the only variable we can control in this department at this time. The European societies also recommend one-time testing in all adults, and to intensify LDL, blood pressure, and lifestyle targets if lipo-A is greater than 50 milligrams per deciliter. Again, we can't control lipo-A levels, but we can extensively control all the others and be very aggressive, and therefore trying to mitigate kind of that adverse effect of lipo-A. Same thing again with the American societies. Unfortunately, they're only saying to measure in patients with personal or family history of premature cardiovascular disease, and then consider a more aggressive lipid lowering therapy if lipo-A is greater than 50 and LDL is greater than 70.
Okay, great, wonderful. So now that advanced lipid profiling seems to give us much more precise and detailed information about a patient's cardiovascular risk, thanks to traditional lipid profiling, why are ApoB, ApoA, and lipoprotein A not ordered as routine lipid workup for everyone?
That's a very good question. And as with all newly developed laboratory testing, there are a lot of barriers to utilization. One of them being is test availability. So only your traditional lipid profiling, LDL, HDL, and such will be available as in-house testing at most facilities at this time. So therefore, ApoA, ApoB, and lipoprotein A will only be available as send-out, which means a longer turnaround time. And, a lot of providers and patients just like to get results as soon as they can. Also, we have looked at the very weak guidelines in the US, and we all know that insurance kind of likes to hang on to official guidelines. They hold providers accountable. They want them to practice according to guidelines. So therefore, these most advanced tests, ApoA, ApoB, and lipoprotein A, are not typically covered by insurance at this time. It's very unfortunate because it is much, much more precise, and the old markers, LDL, HDL, they're just outdated and definitely not the best we can do. But, from an insurance standpoint, they're saying, hey, we have something we've been using for decades. It works. We're going to keep using it. It's cheap. We don't want these new tests. The only thing that's going to change that is provider demand. That will drive in-house availability of testing at most facilities. Usually labs don't come out and say, hey, we're starting to run test XYZ, you guys should order it. The way it goes is that providers continue to call up the laboratory saying, hey, we really want this test and we're tired of the long turnaround time for sendouts. Can you guys bring it in-house? So until this conversion happens and providers start demanding the tests and asking for it, it will not be brought in-house at most facilities. And again, providers usually practice according to their society or college guidelines. So I don't see anything changing until the societies in the US bring out stronger guidelines recommending these new tests. And then, of course, you just have your awareness. So there's a very, very long tradition of LDL, HDL testing. It was one of the first laboratory tests out there. Providers and patients are comfortable with it and they understand it. I think you can talk to anybody out in the streets and they will know what cholesterol is, what good cholesterol is, what bad cholesterol is, and why it matters. So it's just something, that's very hard to change when it's so ingrained in providers and also society in general.
That's interesting. Thanks so much for this valuable content you've shared with us. I hope that the audience would have been empowered to know what to ask the doctor, know if you have a family history of cardiovascular disease, whatever exists in the family, or you're just of age to you're 20 and above, you want to start being concerned about knowing your numbers. Know the numbers because they would help you to lead a healthier life. So before we go on to asking for questions from the audience, I would like to seize this opportunity to let you all know that if you love what you've just listen to, please, I would have a member of the team drop a subscription link in the chat window. Subscribe to Lab2Doctors, where we would continuously feed you with information that empowers you on how to communicate with the lab, how to make the most use of the lab, whether you are a clinician or you are a patient or you are a caregiver. And Mary, please, can you drop that in the chat window so that the audience who like what they've listened to can register so that we keep them informed on the upcoming webinars. We have these webinars every month, pretty much towards the end of the month, like the last week of the month. You can be looking out for our webinars to empower you and make sure that you are better informed. If anyone has questions, go ahead on unmute yourself and ask your question or drop your questions in the chat window so that one of us can read it and have the speaker respond to your questions. Ask your questions, please. Whether it's you, whether it's your family member, feel free to ask the questions you have. This is your time to shine. This is your time to ask the questions. Don't rely on your doctor. If you're a patient, don't rely on the doctor. Sometimes they're expecting you to give them information. So that's why we are empowering you as patients, as caregivers. If you're a clinician, that's why we're empowering you as lab professionals so that you know how best to communicate with the lab. And I see that the subscription link has been dropped in the chat window. Please, anyone who is interested in empowering themselves about lab testing, about what to order, when to order, why order this test when you have these symptoms, please click to the subscription link, subscribe to Lab2Doctors, and you would get this information firsthand before anybody else. Any questions? If you don't have questions, I would have questions for you. Any questions, please? And I'm going to call your names. That's the interesting part of my own questions. If you don't ask your question, I will call your name and ask the question. Any questions? Okay, I'm about to call somebody's name here so that you tell us what you heard. First name I would call here is, I see Dr. Ben Array is up. What is the marker we can use to evaluate the quality or the quantity of good cholesterol in your sample? Good cholesterol.
Yes.
I
really apologize. I just dialed in and
okay.
I'm at the grocery store, but
okay.
I guess in the next forum, it just went off my mind. I apologize that I forgot that the meeting was today and at that time. Yeah, so I could have responded to the question, but I wanted to do it based on what the presentation was all about. Okay. I was happy to hear about the new method and I was interested, but I'm sorry. I apologize to the everybody else that just dialed in now.
Okay, great. Not a problem. Thank you. Thanks for joining us. And I'll pass this question on to Miss Casey Lee. What is a good marker for your good cholesterol, Miss Casey? Please, can you unmute? Hello. Okay. Can anybody answer the question? She gave us a marker for good cholesterol, and there was also a marker for bad cholesterol. Just which either of them, whatever you heard, if you think you know the answer, please just tell us. What is a good marker for bad cholesterol and a good marker for good cholesterol? I'll help you. Is it B or A1? It's one of the two. Either is say ApoB, good or bad. ApoA1, good or bad. I've already broken it down for anybody. So it's one of these answers. When you say good cholesterol, pair it up with ApoB or ApoA1. Can somebody try now that I've broken it down? You don't want to go to see your doctor and you pretty much are confused about lab tests when there's Lab2Doctors here to empower you. Juan, can you help us, please? Okay, thank you. Thanks for putting the slides up so that they can see it. I want people to live here empowered. So this is ApoA1 and this is HDL. Is HDL good cholesterol or bad cholesterol? Who can tell me? HDL, is it good or bad? Juan, again, it's you. Juan, is HDL good or bad? Dr. Ben, is HDL good or bad? Did he leave? No, I don't think so. Horvix, please tell us, is HDL good or bad?
Maybe I can try this. So, hello?
Yes.
So I think HDL is a good cholesterol and
Okay.
it's a bad cholesterol according to the presentation.
All right, good. So for HDL, based on the screen you're seeing here, what would be a good marker for your good cholesterol? To ensure that, look at, she just showed us something here. You have 50 milligrams per deciliter of good cholesterol in the picture, left and right. But you notice that the particle sizes and quantities are different, right? And then when you go underneath, you see ApoA1 to the left is 6 milligrams per deciliter and ApoA1 to the right is 12 milligrams per deciliter. So which in this case, which ApoA1 do you think you would prefer to have? Would you want to have ApoA1 of 6 or ApoA1 of 12? Horvix. Can you come off, unmute yourself and tell us which of them do you think is preferable? Your HDL here is the same, but when you look at ApoA1, they're different. Which of them would you want? Which of them do you think is a healthier option? Is it ApoA1 that is 6 or ApoA1 that is 12? Can somebody help him? Anybody want to try? This is a good slide to really hone in on what she just made mention of. Casey, I'm coming back to you. Can you help us here? Casey is quiet. Juwan is quiet. She doesn't want to talk, okay? And somebody's health is wealth. Please, health is wealth. Can you tell us which of the cholesterol would you want to have here? I mean, which of the ApoA1s would you want to have? Is it ApoA1 of 6 or 12? Okay, let me let Dr. Furr tell us. Explain this thing again. I believe you guys did not get the concept here. Dr. Furr, please, can you explain just this image that you showed here so they can get it, know why one of them is preferred over the other? Thank you.
Yes. So HDL, we said, is our good cholesterol. So it basically grabs the lipid depositions and removes them from your arteries. So what we want to have is as much good cholesterol as possible, right, to reverse transport. So in this case, even though the HDL, the traditional method, shows the same number because it measures mass, when we move to the new biomarker, the ApoA1, we're able to count the number of particles. So the higher the number, the more vehicles for reverse transport you have available. So the higher number is preferable in this case.
Can you please move to ApoB slide? Thank you. So we are here. This was the other question I asked. Thank you, Judy. I've seen your response. Thanks so much. So we are now on this was the other question I asked about the marker, a preferred marker for your bad cholesterol. And a question for Horvix. And I think you said it earlier, but I would like for you to say it again. What is your bad cholesterol? How do you call it? What do we call the bad cholesterol? Horvix, please. Are you here? Horvix, are you here? Okay, let's move to somebody else. Health is wealth. How do we call bad cholesterol? What's the name? what is the other name for bad cholesterol? Look at the slide and you'll be able to know. The answer is right here. Or who knows another name for bad cholesterol? Just come up, unmute yourself and tell us, what is the bad cholesterol, please?
So for bad cholesterol, we say it's called low density lipoproteins.
Good, thank you. So who can tell me, looking at this screen in front of you, what is a good biomarker for assessing your bad cholesterol levels? Again, she just explained the good cholesterol levels with an image that looks like this. Who can tell me, and that the name of that biomarker is right on the screen. Who can tell me the name of the biomarker that can be used to assess your bad cholesterol? The other test that you can tell your doctor to order, especially when you have a family history of cardiovascular diseases, heart attack, stroke, and sometimes people with diabetes also have cardiovascular issues. What is that other test you would tell your doctor to order? It's on the screen. I just want somebody to unmute themselves and tell me. Who has seen it? It's hiding on the screen right here. This is a nice hide and seek because you're seeing it already. Leah, can you tell us what is that other test that you would want your doctor to order because maybe an auntie died from a stroke or an uncle died from a heart attack or just, some cardiovascular related disease? Leah, can you tell us? Okay, nobody's talking here. I don't know why you guys are quiet when we are trying to empower you to talk to your client. Yes, go ahead, please.
So for a biomarker for this, I think we can do total cholesterol.
Okay, can somebody else try, please? Thank you for attempting it. Can somebody else try? The answer is on this screen. It's not hiding anywhere else. It's on this screen. That word I'm looking for is on this screen. What is the other test you would ask your doctor? Let's say that you did the LDL test and it was high and it has been consistently high. You really want to know your risk of developing a heart attack. You want to know your risk of developing a... Okay, Hovix has tested ApoB. Thank you so much, Hovix. Yes, apolipoprotein B is the answer. This is the other test you want to tell your doctor to order. If you have family history of cardiovascular diseases, if your bad cholesterol, you see, ApoB is bad cholesterol. It's a marker for bad cholesterol. So you want to tell your doctor to order this test. If your LDL values have been trending high, or they've not been trending high because you are on statin medications, but you also have a family history of cardiovascular diseases and you are on statin medications, you just want to know the fact that your LDL has gone down because you're on medicine doesn't mean that the damage that was already in place has been reversed. You want to know so that you adjust your lifestyle. You'll be telling your doctor to order apolipoprotein B, or otherwise known as ApoB. So looking at this demonstration that she did here, the image here, who can tell me the ApoB level that you would want? According to this, LDL is 100 for both samples. But when the ApoB was tested, one sample had ApoB of 6 milligrams per deciliter, and the other sample had ApoB of 12 milligrams per deciliter. Who can tell me the preferred ApoB level? We just got through seeing the preferred ApoA1 level for good cholesterol. Now we are looking at the preferred ApoB level for bad cholesterol. Who can tell me this? Anyone? Just try. This is the best time to make a mistake. You don't want to make a mistake and die. You want to make a mistake here and then we correct it. Then you are empowered when you're going to see your doctor for the next appointment. So who can tell us the preferred ApoB concentration here? Just make a wild guess. You don't have to be right. You don't have to always be right. Okay, someone says, Judy says, ApoB the ApoB of 12 milligrams per deciliter. Who has a different response to this, please? Who has a different answer to this? If no one has, I'm going to, okay, someone said 6 milligrams per deciliter. That's Casey. So let's let Dr. Ferb put us through this again so that you better understand the correlation between your LDL results and your ApoB results. So Dr. Ferb, please, can you help us with this slide? Thank you.
Yes, so LDL is what we commonly call your bad cholesterol, right? So your LDL levels basically tell you by mass, so by weight, how much LDL you have floating around in your artery. So both of these patients would measure at a mass of 100 milligrams per deciliter. The difference is that their individual particles have different sizes and therefore are different numbers to make up the 100 milligrams per deciliter. The patient on the left only has 6 particles. The patient on the right has 12 particles. So with LDL, that is the one that causes damage to your arterial walls and the plaques and is the risk factor for cardiovascular disease. So I always envision them as tiny little bullets shooting at my arteries and causing damage, right? So on the left-hand side, you have 6 bullets that can cause damage. On the right-hand side, you have 12 bullets. So the more bullets you have, the more plaques, the more damage, the higher the cardiovascular risk. So for this fraction, for LDL, which can be better measured with ApoB as the modern lipid marker, it is more favorable to have less particle.
Thank you so much for that explanation. I hope that we have all now finally understood the difference and why we want a lower ApoB as opposed to a higher ApoB. Like I said earlier in the beginning of the webinar, heart disease is no longer a thing of the old. You have people who are 20 and above dropping dead from cardiovascular related complications. I hope that this webinar has empowered you to, when next you go to see your doctor, think about your family history. Think about family members who are suffering or who have suffered from cardiovascular issues. Think about yourself, your diet, your lifestyle. If you don't even know your LDL numbers, maybe you should start by knowing them so that you know if you need ApoB or not. And if there are no other questions, I would consider this the end of the webinar and have Dr. Fer give us her last word.
Well, thank you so much, everybody, for joining us today. This really is a topic that's near and dear to my heart, pun intended, I guess. But yes, if you have any further questions, my contact information is in the presentation. Feel free to reach out and ask questions, or if you would like, this presentation to be held in your facility to educate provider or lab staff, I think we're more than willing to make arrangement for that. So thanks so much and have a good weekend, everyone.
Thank you. And thanks everyone for joining us. See you next month, last week of next month. Please be on the lookout for our webinar links so you can register and attend. Thank you.
Thank you.
Bye. If you've not clicked the subscription link, it's over there. You have this time to click and subscribe. Last minute before we hop off the link. If you've not yet subscribed, please click subscribe so that you can always be able to follow us and attend our webinars.